Our patient today is a 72-year-old gentleman who presented with a 2-month history of loss of appetite, generalized weakness, and 1 week history of yellow discoloration of his eyes and skin. About 3 weeks previously, he noticed his urine becoming dark, which he attributed to drinking less water. 1 week before presenting to the hospital, his wife noticed a change in the color of his skin to light yellow. He developed generalized itchiness, which had become troublesome, especially at night, that it disturbed his sleep. He also noticed a vague discomfort in the lower epigastric region above the umbilicus, which was accompanied by easy satiety. He had lost about 6 kg in the last 2 months, which he attributed to poor appetite and food intake. On direct questioning, he admits his stools have become pale lately, but does not complain of any abdominal pain or vomiting. There are no bowel habit changes, constipation, diarrhea, or blood in the stools. This part, the continuation of the history, just summarizes to tell you the patient has a history of GERD and duodenal ulcer and positive for H. pylori, for which he was treated. He is a heavy smoker. He had been a heavy smoker and also consumes alcohol. His father and mother both died of cancers. Father died of colon cancer, mother died of breast cancer. Now let's analyze the symptoms in this patient. He's a 72-year-old man, 2 months history, generalized weakness, loss of appetite, and the urine becoming dark, and the patient becomes yellowish, discolored, and also with itchiness. All these will suggest obstructive jaundice, which is of chronic insidious origin, and it is painless. There's no fever, and the jaundice is progressive. So based on this, the most likely possibility will be the triple cancers of the carcinoma head of pancreas, cholangiocarcinoma, or ampullary carcinoma. This is again supported by the fact of a vague discomfort in the lower epigastric region, but the pain is not so severe. Other conditions to consider for this vague epigastric pain will be GERD, duodenal ulcer, and stomach cancer. And in these conditions, jaundice is unlikely to be accompaniment. The other possibility is, of course, pancreas head of the carcinoma head of the pancreas. The other important features will be is also a diabetic patient. So from the history, the diagnosis is a provisional diagnosis of carcinoma head of pancreas, and the others can be differential cholangiocarcinoma, periampullary carcinoma, stone in the common bile duct is still a possibility, bile duct strictures, and chronic pancreatitis with bile duct obstruction. Now, these are the questions as far as the history is concerned. We shall go through them one by one. Highlight the important symptoms in this patient's history. Okay, these are the important symptoms in this patient's history, which I've already mentioned earlier. Secondly, what are the possible causes of the chief complaints in this patient? Again, it must be some form of anemia, which is a medical cause, or can be a surgical cause. Among the surgical causes, we think of malignancy of the stomach, colon, pancreas, and esophagus. Liver cirrhosis may be another cause, and of course, medical problems like chronic cardiac failure, chronic renal failure, and blood dyscrasias. Question number 3. What are the relevant negative symptoms, if any, in this patient? Okay. The relative symptoms are no abdominal pain, no change of bowel habits, no bleeding PR, and there's no family history of similar problem. The next question is, the patient did not have any significant pain. What is the meaning or significance of this painless condition? It is a chronic problem which is of insidious origin and most likely to be a malignancy in origin. Is the weight loss of significance? If so, what is its significance? A weight loss of 10 kg in 6 months is significant, and it is significant for a malignant cause for the malignancy as a diagnosis. Okay, now coming to the examination of the patient. On examination, he appears to be cachectic and unwell, slightly dehydrated, thin looking, and obviously jaundiced and slightly pale. The blood pressure is normal, but the heart rate is slightly on the high side. It's got mild tachycardia of 90 beats per minute. There is no cervical lymphadenopathy and no stigmata of chronic liver disease. The abdomen is flat, no scars or other abnormalities seen in the umbilicus or other parts of the abdomen. Palpation examination reveals a firm liver edge around 3 centimeters below the right costal margin, with its upper border at the 5th rib on percussion. A tense cystic mass which moves on respiration is palpable in the right hypochondrium. It was non-tender and mobile. Shifting dullness and fluid thrill are negative. No definite masses were palpable, especially in the epigastric and paraumbilical areas. There was minimal tenderness above the umbilicus, but no guarding. The inguinal areas are normal, and the digital examination of the rectum is also normal. These pictures depict the physical findings demonstrated by this in the case. Okay, patient is a 72 elderly man with very gross jaundice. Okay, this jaundice is called deeply jaundice, and it involves not just the eyes and mucous membrane but the whole body. The next one is a mass in the right hypochondrium here. Okay, which moves well with respiration and is mobile, is smooth, non-tender, and also seems to be expanding towards the right iliac fossa. So this lump here, this swelling in the right hypochondrium, is most probably a palpable or distended gallbladder. Okay, now let's look at the important signs that we detected in the patient. Patient is cachectic and looks unwell, dehydrated, deeply jaundiced, the word deeply jaundiced, and pale. Heart rate slightly on the high side, 90 per minute, mild tachycardia, and the liver is enlarged 3 centimeters below the costal margin. It is non-tender and firm. There's a tense cystic mass in the right hypochondrium, which is mobile and non-tender. There's minimal tenderness over the lower epigastric region above the umbilicus. Looking at this, the patient must be most probably looking at these features these signs, it must be having some form of malignancy that cause obstructive jaundice. Okay, the triple cancers, pancreas, head, cholangiocarcinoma, and ampullary carcinoma. The possibility of CBD stone is unlikely in accordance with the Courvoisier's law because of the enlarged gallbladder. The other conditions can be stricture of the CBD, the liver cancer, especially hepatoma with the mass in the right hypochondrium, lymph node obstruction of the bile ducts, or chronic pancreatitis causing obstruction of the bile ducts. Okay, just a word about Courvoisier's law. I want to emphasize the importance of the Courvoisier's law. Okay, what does the law says? Okay, a patient here with obstructive jaundice and a distended gallbladder which is palpable. So in these patients, the obstructive jaundice is unlikely to be due to a gallstone obstruction. Okay, having said that, there are exceptions to the law in these two conditions, where there's double impaction of the stone in the CBD and one in the cystic duct, or the stone in the CBD is primary bile duct stones, usually pigment stones. So in these two conditions, the law can have exceptions. So what's the clinical problem in this patient? Okay, the patient is a 72-year-old male patient with generalized weakness and lethargy, with progressive obstruction jaundice for 2 months, with significant loss of weight. Then he was deeply jaundiced, the liver and gallbladder are enlarged, and there's mild tenderness in the lower epigastric region in the center. Basing on this, the most likely cause will be a malignant obstruction of the CBD. This is most commonly due to carcinoma head of pancreas. Less common causes are cholangiocarcinoma and periampullary carcinoma. These are the questions that are posed to you on the physical examination aspects of this patient. Okay, question number 1. Highlight the important positive signs on examination. Okay, these are the positive signs that we detected in this patient during the examination. Okay, which has been all listed and I've gone through them. Secondly, what are the stigmata of chronic liver disease? Okay, the stigmata of chronic liver disease will be over the palms, palmar erythema, dupuytren's contracture or clubbing, over the chest wall, abdomen and chest walls, spider nevi, edema and ascites. Question number 3. Question number 3. What is the palpable globular mass in the right hypochondrium? It is an enlarged gallbladder whose features are soft, cystic, and moves freely with respiration. Question number 4. Is the liver enlarged? If so, what is the significance? Yes, the liver is enlarged. This is due to the congestion of the liver as a result of biliary obstruction. Give a brief clinical summary and the provisional diagnosis. It's a clinical summary of the patient. The patient is a 72-year-old man with severe loss of appetite and generalized weakness for 2 months, dark urine for 3 weeks, and jaundice and itchiness for a week. His stool was pale and also had significant weight loss. There was no abdominal pain, no change of bowel habit, constipation, diarrhea, or blood in the stools. On examination, he was cachectic and jaundiced. The liver was enlarged 3 centimeters below the costal margin, smooth and non-tender, and the gallbladder was also palpable at the right hypochondrium. With this, a provisional diagnosis of carcinoma head of the pancreas with obstructive jaundice is entertained. So, we come to the diagnosis in this patient. The provisional diagnosis is carcinoma head of the pancreas with obstructive jaundice. The differentials being cholangiocarcinoma, periampullary carcinoma, cholelithiasis, and chronic pancreatitis. Okay, with the diagnosis of carcinoma head of pancreas with obstructive jaundice, let's carry out some blood tests and other imaging techniques. First, the blood test. Okay, one of the most important tests will be to confirm or to ascertain the severity of the jaundice is by doing the liver function test. This includes the following parameters here. Okay, and the most important is the total bilirubin is markedly increased, more than double this normal value. The conjugated is also double, the much more than the more than 50% of the total bilirubin is conjugated, which is abnormal. And the other important factor is alkaline phosphatase, which is also markedly elevated. For normal values, you can look at this chart here. The liver enzymes, on the other hand, are usually mildly elevated or even remain normal. And with the imaging techniques, you have got ultrasound, the first line investigation, where it shows you a very markedly enlarged gallbladder. Okay, distended gallbladder. It may also show lesions in the liver if there are any, and also the status of the situation in the pancreatic head, and also the size of the biliary ducts. Here, this is a CT scan showing you a distended gallbladder here. And then here, there is a mass in the region of the pancreatic head here. Okay, this is a endoscopic ultrasound which shows a mass, either it's a stone or a mass in the head of the pancreas with dilated CBD. Here, endoscopy shows a mass in the duodenum. Here on EUS, you see also the enlarged or distended gallbladder CBD with a mass lesion here. It is either gallstone obstructing the CBD or a mass in the head of the pancreas. Okay, this is a general ultrasonic picture of a patient with a mass in the head of the pancreas. There you see a mass here, an ultrasound, and this is the gallbladder that is markedly distended and palpable. Here again, gallbladder and the mass in the region of the head of the pancreas. Here, EUS just now that we showed just now, there's an enlarged or dilated bile duct with a lesion in the head of the pancreas. And this is, you see through the endoscopy, a swelling, mass lesion in the duodenum. Okay, this is another view of the EUS, endoscopic ultrasound. Okay, this is a CBD which is markedly distended, and there's a suspicion of a mass in the head of the pancreas. Okay, these are the ERCP and MRCP films. This is an ERCP which shows a filling defect in the lower end of the bile duct and possibly a mass in the head of the pancreas. Okay, this is a MRCP, shows you a dilated bile duct and possibly a filling defect here. Okay, here all the various parts of the biliary tract, and there is a filling defect here. This may be a mass there. Now we come to management of malignant obstructive jaundice. Okay, first you have to determine the cause and the operability of the tumor. If it is operable, then you do a definitive surgery, which consists of a WHIPPLE's pancreatoduodenectomy, PD, or a pylorus preserving pancreatoduodenectomy, PPPD. Okay, if the tumor is inoperable, then biliary drainage procedure is usually done, either surgical or endoscopic. Endoscopic is ERCP with biliary drainage and stenting of the bile duct. Surgery is a bypass surgery, cholecystogeginostomy, and choledochoduodenostomy are the popular drainage procedures for as palliative biliary drainage procedures. Okay, we shall not go into the operability of the tumor at this stage. We will do it again in another session. Okay, this is the WHIPPLE's procedure or pancreatoduodenectomy. Okay, this is a triple bypass operation. Okay, this is before the operation. This is the stomach, duodenum, and the gallbladder. So what is removed is a part of the stomach with the whole duodenum. Okay, whole of the duodenum, the gallbladder, and the head of the pancreas. So once you have removed this, then the triple bypass is done. The common hepatic duct to the jejunum, the stomach to the jejunum, and also the jejunum to the stomach. Okay, so this is a choledochoduodenostomy. This is the gastrojejunostomy and also a pancreaticojejunostomy. Okay, this is the triple bypass operation. This is a very major operation and is only done for patients who are fit and the tumor is operable. Okay, this diagram shows you the modified version of the WHIPPLE's operation, which is called the pylorus preserving pancreatoduodenectomy, PPPD. Okay, basically the operation is about the same in principle, but instead of removing the stomach, you transect the stomach at the pylorus. You leave the pylorus intact so as to prevent the reflux of jejunal contents into the stomach. Okay, what you remove is still the gallbladder, the duodenum, and the head of the pancreas, and the stomach distal to the pylorus. So the anastomosis is the same. You have got your end to side choledochoduodenostomy, gastrojejunostomy, and the third one is your, instead of your gastrojejunostomy, it is your duodenojejunostomy. Okay, this diagram shows you the endoscopic procedure of stenting, which is a palliative operation in patients with inoperable tumors. Okay, this can be done by this percutaneous transhepatic stent. Okay, the stent is placed to the liver percutaneously into the biliary system, and then into the bile duct. So this is your percutaneous transhepatic stent. The other one is ERCP. Okay, this is a ERCP where you use a stent through the ERCP to place into the bile duct. Okay, thereby relieving the obstruction of the bile duct. Okay, so this is the ERCP, and the stents are usually plastic or expandable metal or mesh. And the third type is your endoscopic stenting of the duodenum, where the tumor has involved and caused into the duodenum and causes a stenosis of the duodenum. So patient develops vomiting. As it is, to overcome this, you place a stent in the duodenal stricture to bypass the stricture, and this is done through the endoscope. So this is the endoscopic stenting. So these are the three endoscopic procedures to relieve the obstruction of the biliary obstruction or the duodenal obstruction in cancer of the head of the pancreas. So this slide shows you the summary of the surgical procedures or interventional procedures that are available for carcinoma head of the pancreas. For resectable tumors, you do a WHIPPLE's operation or pylorus preserving pancreaticoduodenectomy. For unresectable tumors with CBD obstruction and jaundice, as in this patient, our patient today has got CBD obstruction with jaundice. So you can use a ERCP stenting or surgical methods known as choledochoduodenostomy, choledochojejunostomy, or cholecystojejunostomy. Okay, these procedures, surgical procedures, can be either done through the laparoscopic method or open method. Where the patient has got duodenal obstruction due to involvement of the tumor into the duodenum, then endoscopic stenting of the duodenum could be undertaken. Failing which, you can do a gastrojejunostomy, a simple operation known as gastrojejunostomy to bypass the duodenum.
Finally, this is the flowchart which summarizes the treatment of obstructive jaundice. Okay, patient comes with obstructive jaundice, which has been confirmed with blood tests, especially elevated conjugated bilirubin. Ultrasound of the common bile duct should be done, including the gallbladder. In fact, ultrasound of the gallbladder and biliary tract must be done. If the CBD is dilated and gallstones are present in the CBD, then an ERCP plus sphincterotomy and stone extraction should be done, followed, if the conditions permit, for a leg cholecystectomy laparoscopically. If the CBD is dilated but no stones are seen, then you have to look for other causes of the CBD dilatation, which will need an ERCP or an MRCP and even a CT scan. This is to mainly rule out periampulary neoplasms, cholangiocarcinomas, or other forms of tumors. In cases where the ultrasound of the biliary tract is normal or there's no other detectable cause, then you go for a CT scan and ERCP and treat the causes respectively. If, for example, if you find a stricture, then ERCP with stenting may have to be considered.
Now let's go through some questions on obstructive jaundice. The first question, what is the provisional diagnosis and different diagnoses in this patient? Okay, we have already discussed this in detail. Carcinoma head of the pancreas. Differential will be cholangiocarcinoma, periampulary carcinoma, bile duct stricture, and chronic pancreatitis. Second question, what are the blood and imaging investigations that should be done? Okay, the blood test, mainly a liver function test, ultrasonography of the biliary tract, CT scan, MRCP, ERCP, and endoscopic ultrasound, EUS. Third question, how will you confirm the diagnosis? Okay, confirmation is done by a biopsy or FNAC. This can be either percutaneously, which is very difficult and very inaccurate method, and nowadays EUS has become a standardized operation, a standardized procedure for the diagnosis of tissue diagnosis of pancreatic and lower CBD tumors. The fourth question, outline the management of the patient. First, confirm the diagnosis by the various investigations and the EUS ultrasound, ultrasonic endoscopy and biopsy. Then medical treatment consists of IV fluids, analgesics, antibiotics, vitamin K, and in some patients they may need hyperalimentation. Then the staging of the disease is undertaken to determine whether it's operable or inoperable. If operable, you do a WHIPPLE pancreatoduodenectomy or pylorus preserving pancreatoduodenectomy. If it is inoperable, decompress the bile ducts or do a bypass such as cholecystostomy, cholecystogeginostomy, or choledocogeginostomy. Question number 5. What are the special problems of a patient with obstructive jaundice going for surgery? Okay, these are the 5 major problems of patients, obstructive patients going for surgery. Infection, these patients are high risk patients. They are more prone to infection, so infection is a very important problem that must be handled with adequate antibiotics. Next is bleeding and coagulopathy due to vitamin K deficiency, and in these patients you must be given adequate supplement of vitamin K. Most of these patients are malnourished because of malabsorption. As a result, wound healing is another main complication. So many of these patients should be preoperatively and postoperatively hyperalimented. And early rice tube feeding is a very important measure to be taken after a surgery. Fourth is your dehydration. These patients tend to be dehydrated, and they must be ensured to get adequate IV fluids and electrolytes. And this hydration, if not corrected, can lead to renal failure, a syndrome known as hepatorenal syndrome, where the patient develops acute renal failure in jaundice patients. Thank you.